So welcome to this session named When to Intubate. I'm Erwan from Respiratory in France, and I'm the co-chairman with Louis Talous from Toronto, which must be stuck in another session. So we'll begin, and it's a pleasure to invite Audrey Dejean from the Montpelier team to speak about what's new on the topic.
Hello, it's working okay. So thank you very much of the scientific committee for the invitation. It's a great pleasure and honor for me to be here to speak about what's new, when to intubate, that is the question. So here are my link of interest. And to start this presentation, what is the risk of an intubation? Why is it important to find the good timing of intubation? We analyzed in this study 1,047 intubation procedures and search for incidence and risk factors of cardiac arrest during intubation. We showed that incidence was 2.7%, so almost 3 intubation over 100 are complicated in ICU by a cardiac arrest. And we know from previous and other studies that overall half of intubation in ICU are complicated by severe hypoxemia or severe collapse. What about the risk factors of cardiac arrest during intubation? We have baseline characteristics that we cannot change as physicians, but we found also factors that can be avoided, and among them, there is arterial hypotension and hypoxemia. So more the patient is hypoxemic before intubation, more the risk of cardiac arrest during intubation is important. So it is an important point when considering the timing of intubation. When we talk about difficult intubation in the ICU, it is worth noting that we also found in this study, searching for risk factor of difficult intubation and summarized in the Makocha score, that there were factors related to patient, but also factors related to disease, and among them, coma and hypoxemia, with oxygen saturation less than 80%. This hypoxemia is so a risk factor of difficult intubation. And we also demonstrated that first attempt success, so lack of difficult intubation, is associated with fewer complications related to the intubation in the ICU. So you can see that when you have one attempt, you have less hypoxemia occurrence during intubation procedure. So we fear hypoxemia before intubation. So let's talk about a real clinical case that occurred a few days ago. It was Julia, who is 60 years old. She was admitted in ICU on Saturday for acute respiratory failure due to COVID-19 pneumonia. And it is Tuesday, so 3 days later, and she is under high flow nasal oxygen with a high FiO2, 100%, high flow, 15 liters per minute, and her oxygen saturation is 96%. But the nurse called us because when she's talking, the saturation is now 84%. We alternate with non-invasive ventilation sessions and also periods of awake prone position. There are no signs of respiratory distress and no reduced level of consciousness. So we were on call with my colleague. It was 10 p.m. on Tuesday. So the question on duty, would you intubate this patient? Yes? Who say yes? Okay, and who say no? Okay. So I will tell you later, but you did like we did. we did not intubate this patient, and at the end, we will see what happened. So we know that there are risks of delaying intubation for several years. 20 years ago, it was found that the risk with non-invasive ventilation was to delay intubation. And about 10 years ago, the same risk was found when using high-flow nasal oxygen. There are also clinical studies dedicated to showing the risk associated of delaying intubation. The study of Delbov et al., published in 2015, compared early intubation and delayed intubation. And they found that whereas there was no difference in mortality between groups, there were fewer days alive in the group delayed intubation without renal replacement therapy, without vasopressor, and also mechanical ventilation by day 28. So overall, a worse prognosis in the group delayed intubation. Similarly, the study published 1 year later found that late intubation was associated with increased mortality until 2 years of following after the admission in ICU. Another study published 1 year later by the group of Jean-Louis Vincent and Philippe Bauer showed also similar results. It was a large cohort of critically patients, a secondary analysis of the ICON audit, and intubation of more than 2 days after admission was also associated with increased mortality later in the hospital course. And more recently, this year, the team of Elie Azoulay with Guillaume Dumas and Michael Darmon show in the specific population of immunocompromised patients that time between ICU admission and intubation was a strong predictor of mortality. As you can see in this figure, presented the adjusted probability of death according to the time since ICU admission. Very interestingly, the table E7 in this study reported that only 10 studies, so 42% of the studies analyzed in this review, had defined standardized intubation criteria. In the remaining studies, the decision was left to the clinical judgment of ICU physician. So this is a very important point in the studies assessing the timing and intubation overall or the non-invasive procedure. And it was the subject of the thesis of Baptiste Garborio and Jean d'América that classic criteria for intubation are often non-used and even questioned. So what are the basics, the classic criteria for intubation? Respiratory with hypoxemia, tachypnea, respiratory acidosis, use of accessory muscles, obstruction aspiration, or non-invasive ventilation intolerance. Hemodynamic with cardiac arrest, of course, hemodynamic instability, sometimes arrhythmia, and neurologic with agitation, coma, and need to protect the airway. However, these criteria for intubation are not always stated in clinical studies, and there are often little adhesion to these criteria in clinical practice. So what is the good timing for intubation? We want to avoid an unnecessary complication of invasive mechanical ventilation, and we want also to avoid complication due to excessive use of non-invasive methods. And this was a real picture taken in the room of Julia. It is a clue for the end of the story. So no consensus on criteria of intubation, but what did we learn with all the studies performed recently after the COVID-19 pandemic about patients in acute respiratory failure? A first study showed no difference according to time from admission to intubation. There were 3 periods of time defined, less than 8 hours, 8 to 24 hours, and more than 24 hours. And the primary outcome did not differ the patient disease between groups. However, one study published the same year showed opposite results and showed that you can see here in this figure showing time to intubation, showing hospital mortality in function of time of intubation, that intubation earlier in the course of hospital admission was associated with improved survival. But this year, more recent results found, again, clearly opposite results. And the main conclusion of this study was that in ICU patients admitted with COVID, early invasive mechanical ventilation was this time associated with an increased risk of mortality. So one explanation of these apparent contradictory results or opposite results are the trends in intubation during the COVID-19 pandemic. At the beginning, we were using less invasive methods and less non-invasive methods and more invasive mechanical ventilation. Here you can see across 4 periods of time, increasing of use of high-flow oxygen, increased use of non-invasive ventilation, with decreasing use of invasive mechanical ventilation, and also decreasing use of 90-day mortality. A similar study also published this year in Intensive Care Medicine journal from another cohort this time show impressive results across 4 periods. Period 1, 2, 3, 4, which are detailed here. The use of non-invasive respiratory support was very low at the beginning, 25%, and then increased in period 4 to 80%. Meanwhile, the patient who had only invasive mechanical ventilation decreased from 75% to 21%. So the clinical practice changed a lot. So without surprise, when the meta-analysis of these results was performed and published in Critical Care this year, they include 10 studies from worldwide and more than 8,000 critically ill patients, and they found that timing of intubation may have no effect on mortality and morbidity of critically ill patients with COVID-19. When analyzing all-cause mortality of patients with COVID undergoing intubation without here versus with a prior trial of high-flow or non-invasive ventilation, they found no significant difference and even results non-significant in favor of using first high-flow nasal oxygen or non-invasive ventilation. So the authors conclude that these results might justify a wait-and-see approach, which may lead to fewer intubation. However, the question is where is the line between the wait-and-see and the delay intubation? Maybe at the beginning we were a lot doing invasive mechanical ventilation, and now we are doing more wait-and-see, and maybe we will see similar results than in non-COVID patients. Indeed, the risk of delaying intubation and intubating patients with severe hypoxemia. So the clinical case, Julia, 60 years old. Finally, she was intubated on duty at 2 a.m. on Wednesday, and the saturation was very low. She had signs of respiratory distress, and we had to perform a rescue prone positioning for this patient for severe hypoxemia. So to conclude, there is no magic bullet for good timing for intubation in case of acute respiratory failure. There are classic intubation criteria, coma, acute respiratory failure with signs of respiratory distress, which are the basics. However, there is no consensus and maybe not always relevance to clinical practice. We had to consider underlying disease, the severity and its predicted evolution, and that's why we have to be especially careful in immunocompromised patients. And we had also to consider the operator experience and the team expertise, which is very important when deciding also to intubate or not. And in case of the intubation, of course, it is mandatory to prepare it carefully to limit associated complication, and it will be the subject of a next topo by Samir Jaber. Thank you for your attention.
Thanks a lot for this very nice talk. Is there any question in the audience? One there?
May I have some comments? When you presented the patient, probably you missed the respiratory rate, the use of accessory muscles, all these signs, I mean the Cabrini signs that are cited. And probably this is something that can orient us if we have to intubate or not. In my hospital, I'm coming from Lebanon. In my hospital, the infectious disease do not accept the face mask. When I discussed with Professor Ricard, my friend, he said, no, we are using it and it's not contraindicated. So that's why at the time we decided to intubate the patient, but according to the ROC score, Professor Damien Ricard helped me in understanding and in applying the ROC score. And second, probably using the Cabrini and all the signs, while we know that oxygen also can be toxic to the lungs, so probably early intubation. So early, not too early, I mean. But I agree, the timing is really difficult.
Yes, thank you very much. I fully agree with you. And the ROC index summarizing the signs of respiratory distress with taking into account the respiratory rate is very important to take into account also to decide, indeed. And regarding the risk of toxic oxygen, maybe it is more relevant after intubation and in case of long-term care, but at the acute phase when the patient is very hypoxemic, maybe it's not the problem, the toxicity of oxygen. Thank you.
No more questions, thank you. So we will move on to the next speaker. It's a pleasure to invite Jean-Damien Ricard from Colombes. He will speak about the benefits and the pitfalls of high-flow oxygen.
Thank you very much, Awan. Dear colleagues, it's a pleasure to be here. I'd like to thank the organizers for the invitation. If I'm going to have my slides up. A small delay. There they are. So here are my conflicts of interest in relation with the talk. So Kevin Fisher and Peichel are providing some devices to a multi-center randomized control trial we're currently running, but in the context of hypercapnic respiratory failure. What I would like to address with you and discuss with you this afternoon is obviously the benefits, and we've heard many talks on the benefits of high flow, but perhaps also to alerting on certain pitfalls. Clearly, nasal high flow has undisputedly found its place in the treatment of acute hypoxemic respiratory failure. The COVID-19 has further shown the importance of this non-invasive oxygenation/ventilatory support in helping to manage the ICU bed shortage. But although this universal use of nasal high flow is welcome and I believe should be encouraged, I think we must be aware of potential dangers and pitfalls of this technique. Someone wrote 10 years ago that nasal high flow might be an interesting therapeutic option in case of massive outbreak of respiratory failure during a pandemic in instances of limited or exceeded capacity of invasive ventilation. And this is precisely what we have faced during these 18 months. I must acknowledge, and I'm appalled to recognize that it was a colleague of mine who reminded me that I had written this 10 years ago. Thanks for this, colleague. But this is what we had imagined 10 years ago when reporting our first experience with nasal high flow. And obviously, we were very, I wouldn't say happy, but we were used nasal high flow right from the start of this pandemic. And in this review, I was very happy to lead for intensive care medicine. I'd like really to remind that on the physiological effects, the beneficial effects, they are all flow dependent. So the highest the flow, the higher the benefit in terms of airway pressure, dead space washout, obviously pending adequate humidity. And all this will lead to increase in lung compliance recruitment and will induce a decrease in the work of breathing and increase patient comfort. And so it's really very important to bear in mind the fact that these effects are flow dependent. This has been very nicely shown in several studies by Tommaso Mori. I'll show this one when we look at the identification of the optimum flow for each of these physiological parameters. As you can see, the most effect is observed only with the 60 liter per minute flow and not with lower flow. So it's really very important to bear in mind that in the most severe patients, we will want to use the highest flow. And obviously, as in many publications, we see a level of 50 liters per minute. 50 liters is not 60 liters, and these effects have not been seen for this kind of flow. So what to expect from nasal high flow in the context of hypoxemic respiratory failure? Well, if we're based on the patient's perspective, obviously we want alleviation of dyspnea and respiratory distress, improvement in oxygenation, and a decrease in the work of breathing. And we hope that this will lead to avoid intubation and decrease mortality in the patient. On the healthcare perspective, obviously, and especially in the case of the pandemic, we will expect a reduced for the demand of ventilators, to delay or avoid ICU admission, as has been shown earlier on, and this will help manage ICU bed shortage. Alleviation and dyspnea and oxygenation improvement has been shown right from the start with the use of nasal high flow. I've chosen these results from our experience reported 10 years ago, but once again, many other authors have found similar results, and you can't see it's very small, but all these effects were seen within 30 minutes of initiating nasal high flow. So we do have a very rapid alleviation of respiratory distress and patient dyspnea. Avoidance of intubation, this has been shown in the Florali study. I've highlighted the results for the population at the higher risk of intubation, the most hypoxemic patients. And you can see on the Kaplan-Meier curve that the patients treated with first-line nasal high flow had a significant reduction in the incidence of intubation in comparison with standard oxygen and non-invasive ventilation. So clearly, high flow can avoid intubation in these patients. Decrease in mortality, this was shown in this study, was a decreased mortality with nasal high flow in comparison with standard oxygen and non-invasive ventilation. This slide has been already shown by Audrey in her talk, and I'll go very quickly over it. There again, suggesting that the increase in the use of nasal high flow over time was associated with a decrease in intubation during the first 24 hours, obviously a decrease in invasive mechanical ventilation, and altogether a decrease in the 90-day mortality. Obviously, this is only an association, and there are many other factors that can explain the decrease in mortality, but nevertheless, it is associated with an increase in the use of nasal high flow, and it's hard to imagine that there's no causality, but obviously there are other factors to take into account. So clearly nasal high flow has its benefits in this situation. This has also been shown by my colleagues in France. In this study, Patients were either treated with nasal high flow or other devices or just standard oxygen. And so they compared those patients that had received solely nasal high flow to the others. And they were able to show that nasal high flow was associated with a reduced proportion of patients requiring invasive mechanical ventilation at day 28. And as you can see, it's quite an important reduction from 72 to 55%. We also showed in our series of patients receiving nasal high flow as first-line therapy in COVID-19 ARDS respiratory failure. We had 116 patients that were admitted. Over 60 were treated with nasal high flow as a first-line therapy. And over a third of the patients did not require intubation. These were very severe patients, and obviously 2/3 of them did require intubation. But the main message that we were able to avoid intubation in 1/3 of these patients, and we did not believe we delayed intubation. As you can see, the median time to intubation was only 10 hours. So clearly, this was one therapeutic strategy that we applied to our patients with, I believe, quite a good result. So all these are the benefits of nasal high flow, and I'd like now to focus on the potential pitfalls and dangers of high flow oxygen. I think we can categorize them in two parts. The overuse of nasal high flow, which is excessive prolonging of the technique, and the risk is, as already alluded to, delaying intubation. And clearly one way to overcome this is to have tools to have an early recognition of failure. And the other pitfall is, on the contrary, the underuse of nasal high flow, linked to inappropriate flow titration. And this is a risk of the failure, but it's not the failure of the technique, it's just because the setting is not optimized. And clearly one way to overcome this is to optimize the settings of the device. I'd like to illustrate this. So the underuse of nasal high flow, this study coming from Spain, it was during the H1N1 epidemic in 2009. Patients were treated with nasal high flow, as you can see. 9 were successively treated, and 11 out of 20 required subsequent intubation and mechanical ventilation. But if we focus on how nasal high flow was delivered, as you can see, the flow was only 30 liters per minute. So obviously, we had the question in mind, well, how would these patients have evolved if they had received 60 or 70 liters per minute? And there again, I will show you the results from Tommaso's Murray physiological study. We have very few beneficial effects at 30 liters per minute. Another illustration of this potential pitfall is from the Recovery Respiratory Support study, which is in preprint in meta-archives. And again, the flow was 50 liters per minute. You know, this study is negative for the comparison between nasal high flow and conventional oxygen in terms of reduction in intubation. And there again, we can question the fact that these effects, positive effects, have all been shown at 60 liters per minute. And once again, perhaps it's just the technique that was inappropriately performed. Now, on the overuse of nasal high flow, there again, Audrey alluded to this study, which was a retrospective study in South Korea, where they looked at all the patients who had received nasal high flow that failed. That means that they required intubation between January 2013 and March 2014. And these patients were arbitrarily classified as intubation started within the 48 hours of nasal high flow or after 48 hours of nasal high flow. Even if it's not clearly stated in the paper, importantly, these patients were predominantly receiving nasal high flow outside the ICU and were then admitted to the ICU for intubation. When we saw these results, obviously it was striking to see the difference in mortality between these two groups. Early intubation, 39%, which is still a quite relatively high proportion of deaths, and late intubation was over 65%. So a tremendous increase in mortality when intubation was performed after 48 hours of use of nasal high flow. But if you look into the details, and it's always very important to look into the details of the paper, in fact, this 48-hour cutoff to split the cohort in two does not correspond to the reality. I've highlighted this, the time and the duration of treatment in both groups, and as you can see, in the early intubation group, in fact, the median time of nasal high flow was only 10 hours, and in the late group, once again, the cutoff was 48 hours, but the exact true duration, mean duration, was 126 hours. This is 5 days of continuous therapy that is failing. So I think these results quite nicely highlight why there is such an increase in mortality. So clearly, this is something that's not desirable. Timing intubation has been already the subject of debate and demonstrated that during non-invasive ventilation, it could have a significant effect. In this study, coming from Spain, these patients treated with NIV for acute hypoxemic respiratory failure. On the slide, you can see all the patients that failed non-invasive ventilation. They were all intubated. Some survived, others unfortunately died. And one key feature that separated these two groups was the duration of non-invasive ventilation before intubation. And as you can see, the striking difference, 32 hours for those who survived versus 78 hours versus those who unfortunately died. When we look at the literature regarding nasal high flow, at least in our experience, as I already mentioned, in all our series, we're between 4 and 20 hours. So clearly, I think this is something to bear in mind, and it's been also shown, as Audrey has shown you, for example, in Elia Zule's last work, that the cutoff seems to be really between before 24 hours and after 24 hours. And this is illustrated here also too. So the take-home messages on this aspect, clearly I think that nasal high flow should be offered as first-line ventilatory support in ARDS, whether it be non-COVID or COVID patients, obviously in the absence of criteria for immediate intubation, and Audrey has shown you that we're still lacking consensus on these intubation criteria. Clinical surveillance is mandatory, and I won't be at all alluding to the ROX index, because my friend Honor Roca will be doing it just after this talk. I think we have evidence that inappropriate use of nasal high flow is clearly associated with worse outcomes, so we must really focus on identifying early those patients that are failing. We need to avoid excessive use of nasal high flow, which leads to a delay in intubation, but also to bear in mind that we do have, as clinicians, a role when we are setting the device. Optimized nasal high flow settings is critical when bearing in mind the fact that all the beneficial effects that have been demonstrated with nasal high flow are flow dependent. So if we really want to take the most of the device, use it properly, use the maximum of flow. Some patients won't tolerate it, but you don't have to decrease that much the flow to improve tolerance. And sometimes a very small decrease of 5 liters or 10 liters per minute is sufficient to improve nasal high flow tolerance, and you will still have the maximum of the effect. Thank you for your attention.
Thanks a lot, Jean-Damien. Any question in the audience? One there.
Thank you for the wonderful talk. I struggle a little bit. You highlighted the significant duration difference between failure of high flow and timing of intubation. As a simple clinician, I have to wonder, is it the failure of high flow and that we should have intubated early, or is it that the patients just aren't getting better and they're dying? And so when we compare a patient at 4 days and we should have intubated them early, well, they're 4 days out into illness. When I'm in the unit and somebody's not better within 4 days, either I'm doing something wrong or they have a process that's not treated adequately. So is it the intubation delay, or is it that they're not well? And to that end, if they get to 72 hours with the exact same metrics on high flow, do you intubate them on a timeline accordingly?
That's a very good point. Obviously, it's going to hard to say what is the weight of each contribution, the delay of the intubation and the underlying disease. And I think there's obviously both of them. And it's very hard to say that in this patient, it's 10% delay and 90% the natural history of the disease. Nonetheless, and all the literature is coherent in saying that late intubation is associated with a worse outcome. So I think we need really to strive at least to be sure that our part of the job has been done properly and intubate these patients early. And clearly when we do intubate them, we all know that many of them have to be turned prone very shortly afterwards. And we do have the impression that that's because we've taken perhaps too much time to put them under mechanical ventilation. But point taken, and it's a very good point.
While we're running out of time, we will only have time for one short question, no more.
Well, first of all, congratulations for the presentation.
Thank you.
I have a question. High flow use is not the same before pandemic and in the pandemic. I think that in the pandemic, patients have happy hypoxia. And it's not the same because the patients are able to respire, to breathe with high flow many hours because they are not conscious about the situation of the severity of their arts. And what do you think about this happy hypoxia? Because maybe underuse the intubation or underestimate the necessity of intubation of this kind of patients.
That's a very good point, and I think I'm obviously not saying something very original because we've all, during our rounds and the case that Audrey showed, I mean, this patient is reading the paper and breathing 22 breaths per minute with 90 or 92% oxygen, and we say, well, we're not going to intubate them. They're doing fine, even if it's day 3 or day 4. I think that's where perhaps something a more objective index, and I'll leave Oriol show all the results with the ROX index, perhaps can help us. It won't give us the key answer, but it can help us in deciding when to intubate these patients, because taking into account the fact that they have a lower respiratory rate, perhaps we increase the threshold of, for example, the ROX index. But there again, it's something that I'll leave Oriol discuss. And I think we need these tools that are perhaps more objective than just the subjective impression we have of the patient. But it's a good point.
Thank you, Jean-Damien. So we need to go on to the next speaker, Dr. Roca from Barcelona, about the failure prediction for high flow oxygen.
Good afternoon, everyone. Thank you for the invitation and thank you for being here. I would like to talk about a little bit about predicting failure in high flow patients and focusing on the utility of the ROX index. These are my disclosures, and this is more or less the agenda of our talk. As the previous speakers commented, late intubation has been clearly associated with worse outcomes. We know already from NIV, and it was also confirmed in high flow patients. And this raises the importance of close monitoring. These are 2 different patients with lobar pneumonia. They were non-COVID patients that had practically the same degree of hypoxemia. And if we go outside the chest X-ray and we look to the patients, we can clearly see that they were completely differently monitored. The one on your left side of the slide was intubated. He has an EIT esophageal catheter and everything that we had in our ICU. And if you look to the right side of the slide, you see a patient that was only monitored with a pulse oximeter. So the obvious question is this patient under monitor? Because our aim will be to detect as early as possible any clinical deterioration in order to not delay a needed intubation. Sorry. And the first papers that we had about the variables that were associated with high flow failure were based on studies with a small sample size and very heterogeneous population of acute respiratory failure patients. And they were not discriminant enough in order to identify those patients that will require subsequent intubation. This is where we were before the description of the ROX index, and then we thought that we need something more in order to improve the prediction, and we went back to the roots and we took the paper that I'm sure that all of you know, which is the Martin-Tobin paper about the description of the Tobin index. And if you read the introduction of the paper, the author states that another reason why a predictive index performs poorly is that it does not accurately reflect the true pathophysiological determinants of outcome, which in our case would be the need for mechanical ventilation. And if you go to the circle of patient self-inflicted lung injury and you think about how high flow works, you will see that high flow has some benefits in several critical points of the generation and perpetuation of patient self-inflicted lung injury. And in these patients where high flow does not able to correct the increase inspiratory effort or increased respiratory drive are the ones that will need to be intubated. And if you look to the variables that we can assess in order to predict those patients who are going to fail, maybe the easiest variable are the ones that are marked here with the red square, which is the impaired gas exchange that can be easily measured at the bedside. But if we continue reading the paper, they will give you more information about the pathway that you have to follow in order to describe an index that could predict the success or the failure of high flow. They say that an accurate prediction is more likely with an index that integrates a number of physiological functions. And if you go to the criteria for intubation, for example, that was used in the Florali trial, you will see that you need at least two of the following respiratory criteria. Respiratory criteria was the most frequent criteria for intubation in the study. And probably respiratory rate and SpO2 were the most easy variables to measure at the bedside in these patients. So we went to our population and we tried to predict an index that predicts the need for mechanical ventilation from the measured respiratory variables that we could assess at the bedside that were significantly different among the groups of patients who fail and the groups of patients who succeed, aiming to have an additive effect and increasing our capacity to discriminate between those patients who will succeed on high flow and those patients who will fail. We described the ROX index, which is the ratio between the SpO2 and FiO2 and the respiratory rate, and we observed that a ROX index above near 5 was consistently associated with a lower risk of mechanical ventilation even after adjusting for potential confounding. Indeed, it outperformed the diagnostic accuracy of the two variables separately. But we also try to predict the failure, and we define different thresholds at different time points that were highly specific to predict the fail of high flow. And you can easily think that I show you that you need to be above 4.88 to predict success, and I say that after 12 hours you need to be below 3.85 to predict failure. And obviously between these two thresholds there is a gray zone. And what can we do with those patients that at 12 hours are in the gray zone? Well, we can perfectly reassess the ROX index and see the trend of the ROX through time. And as you can see, those patients who succeed has a delta ROX above 1, meanwhile the others has a delta ROX below 0.5. And there are two obvious questions. We have the traditional criteria and we have the ROX criteria, but what criteria occurs first? Because if they occur at the same time, there is no room for improvement using ROX. We have already a criteria that we know that works, so there is no reason to change it. And here you have represented all these patients that did not meet the traditional criteria for intubation, but they met the traditional criteria, either ROX criteria for intubation at 2 hours, at 6 hours, and at 12 hours. At what happened to these patients? Almost 90% of these patients, they need to be finally intubated, which means that if we had followed the ROX criteria, these patients would have been intubated earlier. And the other question is that we have a ROX value index at 2, 6, and 12 hours. But is this a safe zone? We have seen in the paper of Kang that was published in ISICEM that the threshold that they decide was 48 hours. I'm not very confident, apart from COVID-19 patients that would keep longer times on high flow. These studies were performed in patients with most of them bacterial pneumonia. And we thought that with these patients we need to take an early decision in order to not delay intubation. And the only way that we had to test the hypothesis if the timing of intubation has a role in the increased mortality that we could observe is to take as a reference the mortality that we had in the patients that were intubated in the first 6 hours and compare to the one that the patients that were intubated between 6 and 12 hours, between 12 and 24, between 1 and 3 days, and beyond these 3 days. And what we can say is that at least in the first 12 hours, does not seem that there is an increased relative risk of death according to the timing of intubation. So we are in the safe zone if we take the decision in the first 12 hours in non-COVID-19 patients admitted in the ICU due to pneumonia. And how can we implement the ROX index at the bedside? This is an algorithm that we published with Jean-Damien in ICM last year that is basically the same at different time points, and the only difference is the threshold that you should use to consider intubation. If you are in the gray zone, the recommendation is to increase the support and reassess the ROX index and calculate the delta ROX in order to know if you are more likely to be intubated or more likely to be succeed with high flow. Now we are testing this algorithm in a randomized controlled trial that it's more or less in the middle of inclusion, and I hope that in the next year we will have more results regarding the use of the algorithm. It's important to bear in mind that the flow influences the value of the rocks. All these rocks measurements that you have seen are done at the beginning of the treatment, where we use the maximum tolerated flow. In fact, the median flow was not 60, I'm sorry about that, but was 50 as the main, as the majority of the papers that have been published. And we do not include the flow in the formula of the rocks because all patients were treated with the same flow. And therefore, the flow does not discriminate those patients who succeed from those patients who fail with high flow. But of course, if you increase the flow, the rocks may change because you are giving more flow, you are increasing an expiratory lung volume, you are recruiting at some point the lung, and maybe you are giving a little bit more oxygen if you are not decreasing the FiO2. In fact, if you increase the flow from 30 to 60, and this is a post-hoc analysis that we did with Tommaso Mauri from their studies, 70% of the patients increase the rocks with the increase of the flow. And it was this delta rocks increase or variation was correlated with an expiratory lung volume. That means that this increase in the flow, which is correlated with the increase in the rocks index, represents some degree of recruitment. And what happens in COVID-19 patients? Jean Damian already showed this paper. It was from their series, and it was the first report of the use of ROX index in COVID-19 patients in the ICU. And as you can see, more or less, the threshold that we found discriminative between those patients who fail and those patients who succeed was more or less the same that we have previously described in non-COVID patients. As he pointed out, it's a little bit higher probably because of the fact that respiratory rate in COVID-19 patients is a little bit lower by the presence of some degree of happy hypoxemia. But it has been also used outside the ICU, and this is a very interesting study that included more than 700 patients that were treated in the medical ward, and the aim of the study was to predict the validity of the new early warning score in terms of adverse outcomes comparing to the ROX. And interestingly, applying the ROX, the majority of the patients triggered 4 hours earlier than using the new early warning scores. And applying the ROX at the bedside, it's less than 5 seconds. If you have a calculator, you only have to make the ratio and you have it as soon as possible, as early as now, here, and wherever you will be in the world. So just to finalize, if you are using any kind of non-respiratory supportive therapy, it's extremely important that you clearly predefine your criteria for escalation of treatment before starting the treatment. And high flow patients treated, acute respiratory failure patients treated with high flow need be closely monitored to detect as early as possible any clinical deterioration. And in this regard, ROX index may help to predict outcome of these patients, especially those who had pneumonia. In case it can be easily and repeatedly measured at the bedside, thereby contributing to the day-to-day clinical decision-making process of critically ill patients treated with high flow. Thank you very much, and I will happy to take any questions you may have.
Is there any questions?
Yes, thank you for the excellent lecture. About the rocks, I mean, you said that traditionally, you put the slide about the traditional, clinical approach about the gray area, which you're not sure should we intubate or not, and the use of rocks. I mean, what do you think about that? Should you go always for the rocks? Because sometimes, especially in COVID patients, with the happy hypoxia, I think it's difficult to decide. I mean, it's still subjective. I know you aim for objective criteria, but I think it's still subjective as well. Depends on the person and the patient.
I fully agree. I mean, the data that we have with the ROX index is purely observational. So it only may help to know if your clinical judgment is according to the ROX or not. But the decision to intubate, my suggestion today would be to be based on the traditional criteria that we have and the clinical judgment when you assess the patient. Not only based on a number that you have on the ROX. The ROX will say you if you are in the good direction or not when you have some doubt, but base the decision to intubate only with a number, I think it's not the best approach that we have today, for sure.
Thank you. Another quick one about the duration. You said the time, the safe, you said 12 hours, but some people you can wait up to 2-3 days. I mean,
yes.
They can get away without intubation.
Yes, but because the patient is not, I mean, you have different kind of patients. You can start high flow and the patient is completely comfortable and nothing happens and he could remain with an FiO2 of 0.5 and 60 liters per minute, 3 days. And he or she is perfectly comfortable. And then after 3 days, something happens. Maybe there is a superinfection, maybe there is positive fluid balance, whatever, that makes the clinical situation change. Then it's time 0 for me. And then you have to correct this situation as soon as you can, or take a decision to escalate the treatment as soon as you can if you cannot correct the situation. Another different situation is that you start high flow and there is no improvement. If there is no improvement and you have a ROX index of 3.5 and you are 12 hours with 60 liters per minute FiO2 of 1 and awake proning, you need to escalate as soon as possible, I think.
Okay, one short question, one short response.
I hope it's short. It might not be. Markus Krivas, Helsinki, Finland, nice presentation. Have you, or has any paper looked at why the delayed intubation is associated with worsened outcome? Why do the patients die? Is it so that when you intubate them later, they are extremely hypoxic? Because you still think that if you're on nasal flow, you're not getting sedation, you're not paralyzed, you're talking, you don't get ventilator-associated pneumonia. So unless they crash completely and have a cardiac arrest, then I can understand. But why would it otherwise?
Because I think that all are hypotheses, but as I commented before, it's a different situation, a patient that is completely comfortable with no inspiratory effort, that can be breathing calmly for several days with high flow at 50 liters per minute and 0.6, and another that has a high inspiratory effort that could not be shown by the respiratory rate that promotes what we call as patient self-inflicted lung injury, that when you intubate this patient, you go directly to ECMO, practically, because the lung is completely stiff when you arrive to intubate them, and then is the worst situation that we may have. And this is the situation that I would try to avoid in our clinical daily practice, because we are an ECMO referral center, and one pattern of the patients that we receive for ECMO are patients that have been breathing at high respiratory rate with non-respiratory supportive therapies, whatever, high flow or NIV, for several days without any improvement. And then after 5 days, they were intubated, and when they were intubated, the patient's self-inflicted lung injury is completely increased, and it's impossible to ventilate these lungs. So I think that there are different situations, and when the clinical deterioration, if you start the high flow or NIV and the patient stabilize, you can be confident that you can keep the situation unless there is another clinical deterioration that appear. But if you cannot change the clinical deterioration that motivates that you need to escalate the treatment to high flow or NIV, you have to move faster to invasive mechanical ventilation.
Okay, thank you very much. We need to move on. We don't have time for the pause, so it's a pleasure to introduce the next speaker, Professor Samir Jaber, that will talk about the potential improvement of the endotracheal intubation process. Don't fall.
Thank you, Erwan. Ladies and gentlemen, it's my pleasure to be here. This is my conflict of interest. So, I think my presentation will be more easy than the beginning, because the previous speaker presented several slides they will present to you, so we will win time probably. My first slide, I think it's very important to remember this for the more young people in the room, that the risk number one for the intubation is intubation and difficult ventilation, so leading, as we know, severe hypoxia, cerebral anoxia, and then the maximum is cardiac arrest associated or not with death. So in case of difficult intubation, first priority over everything else is oxygenate. Please, this is your only priority that you could do, not try to put the trachea in the tube, but the more important thing is oxygenation, and at the same time, please call for help. This is probably the main slide that you should read. So, more than 15 years ago, we performed this multi-center trial in some center in the south of France, and we reported first that around half of the intubation have been associated of complication, severe and non-severe complication, and half of this are associated with severe life-threatening complication, as you know, such severe hypoxemia, severe collapse, cardiac arrest, or death, and less severe complication. So more recently, in this study, this study published this year, the Intube study, which is a multi-center trial, including 3,000 patients in the world, reported 15 years later very, very similar data. It's absolutely very similar design. However, as you know, we found probably less severe hypoxemia. Maybe it could be explained by the improvement, maybe, of pre-oxygenation. We don't know if it's a high flow or non-invasive ventilation, or both could improve this. But it's very important to see that few decrease of complication was reported. So, as presented by Audrey, this is the ultimate complication of intubation, is the cardiac arrest, and is always reported around 3% in a different study, observational or randomized trial. And please note that the mortality of the patient who presented a cardiac arrest during intubation is twice than those who never presented cardiac arrest. This may be very important from some decision. We compared very comparative groups, and we found 73% in comparison to 30% in patients who did not presented cardiac arrest. So, as we see, this is the main predictor of cardiac arrest, then could be modified. So, arterial hypertension, this is a major point that you could anticipate. The hypoxemia also, the pre-oxygenation should be optimized, and elderly patient could not be modified. So, could we better identify patient at risk for difficult intubation? Audrey presented this Makocha score, which a score, it's the first score predictive factor to the difficult intubation. It's not retrospective, but predictive. And as you know, it's composed by different factors, some related to the patients, as you see here. The Mallampati score is probably one of the most important things. They're related to pathophysiology, coma or hypoxemia, and related to the operator. The score is ranged from 0 to 12. It's easy to calculate. And then from 0 to 3, you have a low risk for difficult intubation. From 4 to 7, it considered as intermediate, and high to 8, it's probably at high risk. So when you are on dirty and you have a patient in ICU, please always consider to evaluate the risk of difficult intubation. This should not be reserved for the anesthesiologist, should be also for intensivists in ICU. Never forget to evaluate the risk for intubation, especially patients under non-invasive support such as high flow oxygen therapy, non-invasive ventilation. You should always try to evaluate the risk of intubation, of difficult intubation. So the question is how we can do better to endotracheal intubation in ICU. Now we better identify these 20 years that the risk, the type of patient, and then probably we try to improve this. For this, we now work more than 25 years on the subject, and to summarize our work, first of all, a good preparation of the patient and the material. Second point, a good pre-oxygenation, probably is one of the key message. Third, try always to have a prevention of the collapse, and probably fluid loading or vasopressor use combined. Not a single one, but probably both combined could improve. 4 is to use the good drugs for the induction of anesthetic. That means the good hypnotic without too much cardiac depression. You use no morphinic, it's not recommended in this acute situation, and probably you should use more relaxant using RSI. And finally, please, now I hope that all of you have the capnography in your unit to check if the tube is correctly inserted in the trachea. So, how improve this with the 5 main practices? First of all, the preparation. It's very easy. You should monitor the patient, the venous perfusion, remove all the prostheses, moderate proclive position each time when it's possible. Try to adapt position, this when it's possible. Have nurse, material, drug dedicated for this intubation procedure. Now, it's recommended to have in all units this following dedicated trolley. Don't imagine what you want to do, just go to your operating room and do exactly the same, copy-paste what happened for the operating room and do exactly the same as you see here. Other things is the use of video laryngoscope. Now, close to 10 years ago, with our group, leading by Audrey de Jong, we performed a before-after study with the implementation of a combo video laryngoscope. The combo video laryngoscope could be used as the classical Macintosh laryngoscope and also this a new video laryngoscope. This is very good because in your department, if you have some physician who are opposed to introduce a new technique, you can use it as a Macintosh classical one. And we reported that we could decrease the difficult intubation on all difficult laryngoscopy. We performed in the same time this meta-analysis, and we also, according to the meta-analysis performed more than 8 years ago, a decrease of frequency of difficult intubation using video laryngoscope in comparison to Macintosh, a significant decrease of the frequency of, increase of frequency of first attempt success, which is a good surrogate of the quality of the intubation procedure. And this was also found in the more recent meta-analysis in this study published a few years ago. However, in this very nice French study with our friend Jean Lascarou and Jean Renier, which was the first large randomized controlled trial in intubation in ICU, unfortunately, the others find no significant difference between the video laryngoscope and the classical Macintosh. This was very surprising, and one probably major explanation is that close to 84% of the operators are non-expert. Non-expert means never used or very few users in this situation. This may explain also that in the video laryngoscope group, you have a signal for more severe hypoxemia. One explanation is see here is probably, as reported by this study leading by Boris Jung, that probably to be expert, at least you need to have performed 15 video laryngoscopy attempts. This is a very important. This means 15 video laryngoscope in ICU patient, not in mannequin. It's not the same thing. So during this COVID, we reported our practices very early that video laryngoscope can really improve the intubation procedure and probably could decrease the risk of contamination due to the COVID. This is, as you know, is Audrey. As you see the difference between this, a little bit exaggerate, I think, and this is the real life. Yes, we can discuss this, you can ask Audrey. So for pre-oxygenation, thanks to Audrey and to Jean-Damien, especially for, there are some slides I showed. One important thing is this, the New England Journal paper was a such paper, not good paper, but it was accepted in New England Journal. Why it was accepted? No, it's not good paper. Because it's a paper which changed a paradigm. When you are an editor and you have a paradigm that every physician believes since more than, I don't know, 16 years, 17 years, but you have no study which evaluated this, and then you have a study which is a provocative study, very aggressive, provocative, and change the paradigm. The editor will accept your paper because it's sure that it will be very cited. And then this is a very simple message, is that among critically ill patients receiving bag mask ventilation had higher oxygen saturation and the lower incidence of severe hypoxemia than those receiving no ventilation. The message classically is to not ventilate patients with empty gastric in this situation. And this changed all the message that you have. That's why the paper was accepted. Please read the correspondence with and the nice editorial accompanied this paper. So, pre-oxygenation before intubation, we have now different approach. Use positive pressure, CPAP or non-invasive ventilation. Use high-flow oxygen cannula, as nicely showed by Jean-Damien. And maybe combine both, not competitor, but probably synergic strategy. This slide is a very classical one that we performed it more than now, 15 years ago. I don't remember if Ewan was with us in this period in Henri Mondor when we performed this first. We developed first the non-invasive ventilation in COPD patient first, and showed that intubate patient with pressure positive ventilation is really better than spontaneous breathing. Second is high flow oxygen cannula. This is the paper from the group of Jean-Damien Ricard, who reported to us that you can use high flow oxygen therapy to optimize pre-oxygenation in mild to moderate hypoxemia. And this is a very nice study because it's safety, shows the safety, the efficiency, and the message is very good because you have no problem in this trial and you could improve the quality of oxygenation storage. So, unfortunately, when the French group performed this randomized control trial, find no significant difference. This is a little bit complicated to explain, but probably one major difference may be that in these studies, the patients are more severe than the previous one. We can discuss with Jean-Damien, but maybe it's one explanation that can explain this, and also it's a prospective, not retrospective study. So we try to develop a new strategy which is called OptiNIV for OptiFlow and non-invasive ventilation, which combine both pre-oxygenation in non-invasive ventilation. You benefit of the positive pressure, which allowed alveolar recruitment. This is open the lung. This is probably good. And we also associated the apneic oxygenation with high flow oxygen therapy. And this allowed the continuous oxygenation insufflation during the laryngoscopy. Then we associate the both positive effect of the two strategy, not opposite. So we performed this study, and we showed, in comparison to our non-invasive standard pre-oxygenation in our team, that we could also improve the quality of pre-oxygenation by obtaining significantly lower minimum SpO2 value in the group of OptiNIV. So the drug, we don't have time to develop the drug, but please consider always the mural laxant. Hypnotic, as I said, probably you should use etomidate, ketamine, or propofol, but carefully. No morphinic, and the mural action should be considered cellucurine without any contraindication, or the rocuronium if you have contraindication. My message about the hypnotic is probably in this patient with a high hyperadrenergism, high hypersympathetic reaction, please, low is yet enough. This is probably the key message and the secret to have less collapses. So, taking all this, we developed the Montpelier intubation protocol, which included all what I developed with pre-intubation fluid loading in a non-cardiopulmonary edema patient, use vasopressive drug. Now in our unit is absolutely systematic, is mandatory to use. Whatever the arterial blood pressure of the patient, we start with a low infusion, 0.5 or 1 milligram hour. This is very important, and this is more and more if the diastolic pressure is low, which is a surrogate of vasoplasia, especially in the sepsis patient. Pre-oxygenation with positive strategy, mainly non-invasive positive pressure ventilation or the association of both with high flow. Prepare long-term sedation to avoid a wake patient just after. Always try to have 2 operators, that means 4 hands. This is probably better. The procedure used a rapid sequence induction, an RSI, as I developed with Selic maneuver. And post-intubation, please always check with capnograph. This is the main concept of what I said, and performing this, we reported in this before-after trial a significant decrease by half of the major complication, less hypoxemia, less collapses, and less cardiac arrest, but we need a lot of number to show a significant decrease for cardiac arrest. This is an update, which will be published in the next days in intensive care medicine. As you know, we increase the number of recommendations, especially we added this strategy which included a stylet versus no stylet in a patient intubated with Macintosh laryngoscope. In this randomized controlled large trial performed in France with all our groups, we compared using stylet without stylet with classical laryngoscope, not video laryngoscope in this study specifically, and we tested the effect on the first attempt as a surrogate for the quality of intubation, and we showed a significant increase using, as you see here, the stylet, 78% in comparison to 71.5%, and this with no side effect. This was considered as a positive study. Then now we recommend to use a stylet with the classical laryngoscope, and often for the video laryngoscope, we don't have the answer, but all the companies recommend to use stylet for the video laryngoscope. So don't forget, please, the capnography. And the conclusion of my presentation are the following two slides. First of all, please consider intubation in ICU patient. That is a very specific approach. It's absolutely different than anesthesia patients. Second point is that evaluate always difficult intubation criteria, especially in the patient under non-invasive ventilation support, high flow oxygen, non-invasive ventilation, CPAP. All these patients are at risk to be intubated. Then evaluated the difficulty criteria using Makochka. Use internal protocol. You have several protocols now published from different savant societies. Improve pre-oxygenation. This is probably one of the most important things to do. Prevent is better than cure. Capnography should be systematic. Applied RSI, as you know. And obviously, the formation training, consider mannequin and simulation. You can go to Brest. Probably you have one of the best simulator. Not him, but the simulation. And then, this is my last slide. Algorithm should make the distinction between the primary objective, which is oxygenation, and the secondary objective is tracheal intubation. To always consider oxygenation. Thank you very much for your attention.
Thanks a lot for this fantastic talk. Unfortunately, we are running out of time, so I suggest to ask directly the question to Professor Jaber if you have some. I'm not quite sure. So the next speaker will be Dr. Long from Madison about the risk of learning intubation.
Good afternoon. Thanks for sticking it out through a long day. I'll wait for the first slide to come up. So I'm Micah Long, and thank you very much for having me. I'm a critical care anesthesiologist. I practice in the United States, which I don't think we have a lot of people from the US here. And so some of my talk reflects some of our practices. I direct the training of our non-anesthesiology critical care fellows in how to intubate. And so today's talk will be a little bit of a spin from an educational approach, trying to address the question of when it's acceptable to allow a trainee to intubate a high-risk patient and when the most experienced person in the room should take over. I call this high-risk learning. I don't have any conflicts of interest. This became intensely important to me. It was the second week of my fellowship in critical care. I just finished anesthesiology training, and I was asked to intubate a patient by another intensivist. And the patient was very large with horrible lungs, a horrible airway exam. He was septic and swollen with a bowel obstruction, and his oxygen parameters were horrific, barely maintaining a saturation and actively aspirating anytime we dropped below 45 degrees. I grabbed a colleague to expedite the intubation, and as we were setting up, the resident physician responsible for the patient arrived, and he brought all his airway equipment. He was very excited to do the intubation, and I was forced to make a call on whether I take over and rob him of the learning opportunity or whether I let him try on a patient that may have collapse. I elected at that point in my life to take over. We got the airway. It looked quite easy. It wasn't in truth. We made a lot of very rapid adjustments that we could only do because we had a lot of experience in intubating critically ill patients, but it looked easy enough that he got absolutely furious with me. And it made me question a lot of my decision to take over. In addressing the question of whether we let trainees intubate the critically ill, we are faced with a lot of data that supports the idea that our critically ill intubations are exceedingly difficult. They're not only technically more challenging, which has been reviewed several times, but they're challenging with regards to the space you're working in, which isn't ideal. As an anesthesiologist, I'm so used to having all of my difficult airway equipment within my right arm's reach. It might be outside of the room. Your monitors might be far away and not making the noise you're used to. And if you call for help, it may not show up in time. The patients are also physiologically difficult. They can't tolerate hypercapnia or hypoxia, and all of your backup plans are possibly not available. You certainly can't wake up a difficult airway if you're intubating them for hemodynamic instability. In the face of all of this, they are frequently unsupervised. In our US model, this study showed that only 36% of these airways had an expert intubator present during these airways, and that's representative of the hospitals I've worked at. And possibly as a, no, the button's not working. Possibly as a result of this, or at least a contributor to this, they are complicated. The incidence of difficult mask and difficult intubation is far higher outside of the operating room in these intensive care unit patients, with total failure of both about 1 in 1,000 times, or 1 per 1,000 times. Complications have been reviewed several times, but I'll say they're over 6-fold more likely to occur outside of the operating room environment, and these are for life-threatening complications, horrible systolic blood pressure under 80. And cardiovascular collapse happens not only in the ones you anticipate, but in ones that were stable beforehand. In about 1/3 of the time, if you had normal hemodynamics beforehand, you intubate them, give them a little bit of sedation, they end up with hemodynamic instability afterwards. Well-done studies, Dr. De Jong's study is listed in the top left here, have shown incidences of complications of each individual complication that's severe of 25% or so, with total complications happening with intense frequency. Other work has shown that difficult technical airways, so technically difficult airways, are associated with these hemodynamic complications. And this is not only associative, sick people are sick and bad things happen, but it's causal. As you're struggling to intubate the patient and working down the technical backup plans, it's very hard to divide your attention to managing induction medications wearing off or hemodynamic instability and how you rescue it and with what doses. One of the ways we strategically assess for difficulty and translate that to learning in an educational environment is with first pass success. And first pass success has been brought up a couple times today. It's been known since early 2000s. This bottom left figure is a study done by Dr. Mort in 2004 that showed if you manipulate the airway more than 3 times, complication rates go up. Of course, related to the airway being so vascular that as you mutz around in there, it gets much more challenging, but also because of the technical and hemodynamic consequences I talked about a moment ago. It's been replicated in the emergency department in the top left figure. And meta-analyses also support this idea. Basically, as you mess around more and more things go wrong, and they absolutely deteriorate. When we look at first pass success from an educational perspective, we're faced with a lot of data that's in very elective scenarios, the operating room. And in the operating room, I sadly admit that anesthesiologists are the slowest learners, and we tend to get to 80% first pass success in 40 to 50 or so, sometimes on the high end, whereas paramedics and EM physicians in the United States model learn a lot faster. I think the pressure of knowing they aren't going to have as much time to learn it, and they're going to do it in a life-threatening situation helps their learning a little bit. But once you get past 80%, things slow down, and it slows down drastically. Most work in the operating room tells you you can get to 9 out of 10 of your first pass success at around 100 to 120 airways. What most of that literature doesn't comment on, however, is that it's in the OR and you have a faculty anesthesiologist that's manipulating the airway as you work, adjusting your hand, pushing the trachea over, or optimizing position before you go to sleep, all things that are harder to do when you're learning and under pressure. And there's absolutely work that supports that you don't even get to 9 out of 10 until you're into hundreds of intubations. Now, I know the easy answer to that is that VL has revolutionized things, and there's certainly arguments that you can become an expert at VL much faster, and the meta-analyses support this idea. But when you really take a deep dive into this literature, what you notice is that most of the data saying that VL is better assesses trainees. It assesses people that are easy to test. They're around our hospitals, and they'll say yes to volunteer for your research study. When we look at experts, the VL and DL curves almost unanimously overlap. So interesting study on the right side here is experts on one hand, same timeline, same scenario, non-experts on the right, and it highlights this. Non-experts benefit greatly from VL, whereas for experts, they overlap. And so what I find intriguing about this is VL has never improved our first pass success beyond the pre-VL era of around 9 out of 10. And so while it is certainly helpful in terms of speeding up learning, and it's absolutely saved my butt a handful of times, and it's a useful tool, in a given scenario, you don't want to simply say, oh, well, I learned VL faster and I should give up DL. One or the other may be best for any given scenario, and the more backup tools you have, the better you're ready to deal with complications. When we're given the choice of VL or DL under pressure and look at first pass success, it turns out that 15, 30, 100 intubations aren't enough. And we see marked improvements in first pass success over years of training. The left, top left is anesthesiology residents that were mostly supervised. So this is a very high training environment. We, in this hospital, I happen to know people there, they average around 300 to 400 intubations per resident annually. And so you see these improvements from 300, 600, and 800 intubations. So these skills take a lot of time to develop. And of course, they're technical in addition to learning how to run a room and learning how to manage hemodynamics, but these things take time. Other work done at the University of Washington has shown lower saturation rates with fewer intubation experiences by their fellows intubating in the medical ICU. And when we know that, and we know that procedural hypoxia in varied studies has been associated with cardiac collapse, you're faced with the idea that allowing trainees to intubate actually has a number needed to harm, which is very hard for me to accept as somebody who trains these people. Atul Gawande has this to say about it. We know that we learn by practicing. We learn skill, judgment, and of course technical skills and confidence by practice, whether it's a sport, an instrument, or any other skill we need. It's just that in medicine we practice on people. Of course, this doesn't mean that only experts need to do all your airways. That's insane. You'll lose an entire generation. You have to train people. You learn from struggling and you learn from failure. The only way to know that you can hack it in a difficult airway that's gone wrong is by being in a difficult airway that's gone wrong and working through that process yourself. There's also educational data that supports the idea that actually you do better if you're not taught to avoid complications, but you're taught to make the mistakes and then figure your way out of them. Now, of course, we'd never do that to patients, and this isn't in reference to patient care, but it supports the idea that you're actually worse off if you never get your hands dirty. The idea of that is called the cost of learning. And the cost of learning is this idea that while we have some baseline skill set, and we know that as we train people or change our process that things might get worse for a while, the hopes are that over time, with new approaches and developments, the future gets better. It's simply critical to make sure that your training will actually get you there and not be inadequate. I can't speak to the European model. I can't speak to the United States model. There's a lot of work looking at the number of procedures done by pulmonary and critical care fellow graduates, graduating over a 3-year fellowship with under 50 total intubations in the intensive care unit and operating room environment, emergency medicine doubling or tripling that, 100 to 150 being the average nationwide. In these training models, there's simply not enough time to learn anything but VL, forgetting that there are airways that VL cannot fix. And there's an emphasis on mannequin simulation, which is, of course, useful, and I use it, but it's an interesting thing because skill sets don't necessarily carry over from one mannequin to another, much less from mannequins to humans. Studies that compare outcomes of intubation frequently don't make this statement outright that, hey, we are comparing outcomes of intubation, but we looked at residents versus faculty. It feels a little dirty to do that, and it certainly doesn't make our trainees look very good. But if you go through the methods of the studies and you compare studies that only compare people who intubate professionally, regularly, routinely, 2 years of anesthesia training or 5 years of critical care training, actively full-time critical care, and you compare that to resident-directed models or pulmonary fellow-directed models, which is a typical United States approach, we see that our overall severe complication rates are different. They, of course, overlap in many of the studies, but if you take them all and sum them together, experts do not equal non-experts, and things go wrong more frequently when it involves trainees. Now, thankfully, team or collaborative approaches exist, and they're hugely beneficial. Of course, Dr. Jabert has talked about having 2 people as part of the Montpelier airway algorithm. I'm a huge proponent of that. This is a Scotland urban emergency department that uses emergency medicine combined with anesthesiology, with an emergency medicine physician being the first go at the airway. And in that model, their safety is incredible, and the EM physician is doing most of the airways. And so the idea being that not only does an emergency medicine doctor get chances to intubate that they may not have every single shift, but you have a backup approach and 2 people to help work through challenges. So I would argue that experts can, in fact, prevent complications. We know this when we learn a new skill, play chess, or are figuring out how to golf, that you can teach tips and techniques and read a book chapter on how to do things. It's just not the same as going out and practicing. It doesn't mean you have to be an anesthesiologist. It's certainly how you train, the experiences you've had, and most importantly, and a talk that I give separately, how you can speed up your learning curve and maximize your learning so that you can get there faster than 100 emergency intubations. I do, however, say that there are several airways that I will not supervise, or at least I will not supervise anybody that hasn't had several years of dedicated airway training. The first is when the airway has no space to go. If the airway is already swollen and there's an upper airway obstruction, if I manipulate the airway once, I can't promise that it will not overswell and succeed a second time. The second category is when speed is so crucial, and that's the dirty or messy airway. When they're going to aspirate and the time it takes me to work will make the aspiration worse, I don't allow trainees to take part in that. And the third is for when your undivided attention is necessary. This is very much a judgment call. I focused on hemodynamics here, but you could say the same for severe hypoxia. If you're worried that your attention will not be able to be divided between hemodynamic instability and helping a trainee go through the second or third line approach to the airway, then that is not a learning intubation. There's another day for that. And that's all I had. I know we're tight on time, so I won't keep talking. Thank you very much for your attention.
Thanks a lot for this fantastic talk. We don't have time for any questions, so please feel free to go and ask them directly to Dr. Long. So next speaker is Dr. Hernandez from Toledo about weaning and the cannulation in tracheostomized patients.
Good afternoon. It's my pleasure to finally attend a medical congress physically and not online like all the previous in the months before now. So my slides. Okay. Well, the topic of the lecture is the weaning and the cannulation in tracheostomized patients. I have to say that we have recent advances, important papers that have stepped forward the management of these patients, but unfortunately, this is very few attention to this topic. Even more, many countries, like for example the US, manage these kind of patients or the patients in this phase of the critical illness in step-down units or long-term care centers. So I have to really confess that we have detected by now some milestones that have limited and retarded the management of these patients, but there is really a long road to ride before we totally understand and improve the management of tracheostomized patients. So these are my disclosures with this topic. Okay, the first point I want to talk about is the timing of tracheostomy. This has been revisited many times. Probably this is one of the topics in critical care that have more meta-analysis published along these last years. We have a meta-analysis published since 2014. We have read about conflicting results with different meta-analysis, with positive results, negative results. I think most of us really feel like lost in translation. That could be better said, lost in the statistical analysis, because to overcome some clinical limitations, the statistical analysis of this topic has really been more complex and difficult to understand many times. So I want to mention this meta-analysis that has been published this year in the JAMA. This is, to my knowledge, the last one, and to my knowledge, it's the first one that have found statistically significant results in one of the most important outcomes regarding the timing of tracheostomy, that is the prevalence of ventilator-associated pneumonia. This topic, in my opinion, is very important because timing tracheostomy has clearly reduced the time under mechanical ventilation regarding the time between intubation and tracheostomy, and clearly there are many papers and studies reporting that the time between starting winning attempts and finally liberation from mechanical ventilation is also reduced. But to my knowledge, none of them have demonstrated that patients that early tracheostomy can accelerate or reduce time on full ventilator support. And this is why I consider this outcome really important. This meta-analysis included 17 randomized trials. One of the most important points limiting obtain significant results with this outcome is that, well, to reduce ventilator-associated pneumonia, you have to perform tracheostomy before this pneumonia appears. And, well, timing of ventilator-associated pneumonia runs from as early as 3 days after intubation. So there is, to my knowledge, only one large randomized trial with a primary outcome of ventilator pneumonia episodes. And the problem is that if you have to randomize patients so early that you have to perform the tracheostomy before the pneumonia appears, that really confronts with the difficulty at the bedside of predicting prolonged mechanical ventilation. And that's why many of these randomized trials trying to accelerate the prediction of the prolonged mechanical ventilation fail, and most of them lost close to 50% of the screened patients. So although all we know that randomized trial is the best evidence ever, we have to recognize that for this topic, the best evidence is really limited because of the impossibility to develop any model predicting prolonged mechanical ventilation. So that's why I consider this the last one of today of the meta-analysis published have to be taken into account for clinical decision making. Other important outcomes included in this meta-analysis include the time on mechanical ventilation the patient with early tracheostomy spent and late tracheostomy, and the comparison of them. So another of the problems here is that, well, we are always close to the statistical significance, but we always keep in a trend toward a clinical benefit. And that's the same case for when we analyze the time, number of days on mechanical ventilation. And I think we should quit trying to obtain a significant result of this outcome. And that's why some of the ways to trying to get out of this controversy is change the outcome. So if it's impossible to obtain a significant result for a number of days on mechanical ventilation, we can change to failure-free days, that is ventilator-free days. And this is a composite endpoint including mortality. From a mathematical point of view, when a patient dies, this is a penalty for this outcome whenever the patient dies. So this counterbalances the difficulty. And on the other way, there is no difference between mortality rate between early and late tracheostomy, but what is important is that late tracheostomy have late mortality, although it's the same compared to the early group. So this counterbalance from a mathematical point of view and has obtained significant results with this outcome. And the other point I forgot to mention with the ventilator-associated pneumonia outcome is that the point here is that to obtain a significant result for pneumonia, you have to define early tracheostomy very early. And this meta-analysis concluded that early tracheostomy is defined in the first 7 days after intubation could significantly reduce the pneumonia rate. So after the COVID appeared in our lives, we added a new point for the importance of timing tracheostomy, and that is the overwhelming conditions of the ICU and limited resources to attend so many patients. We performed this retrospective analysis, including close to 700 tracheostomies in the first wave of the COVID pandemic, aiming to elucidate if early timing of tracheostomy can help anyway to overcome these limited resources, principally ventilators and ICU beds. We obtained this Kaplan-Meier curve, and we, because of the previous recommendation in the pandemic, separated and classified patients according to the timing in 5 different groups. That is, patients during the first week after intubation, patients tracheostomized after 8 to 10 days, 11 to 14, 14 to 21, and the 5th group is patients tracheostomized after 3 weeks. And what we observe here is what we significantly observe a reduced number of ventilator days and a reduced number of ICU bed days. Importantly, and in my opinion this adds new information to the arena, is that the earliest the tracheostomy, the greater the benefit. And we made a sensitive and exploratory analysis comparing very early, defined as those tracheostomies performed in the first week after intubation, and compared them with tracheostomies in the second week, and obtained significant results using a propensity-matched score analysis. I think that COVID has helped us in this topic because, as I have said before, predicting prolonged mechanical ventilation is quite difficult before the COVID era, but, well, during the COVID it's quite easy, at least in most of the patients, and we can perform stronger models to more comparable groups. And, for example, we observed that patients in the very early tracheostomy group, that was 65 patients, the propensity selected 59. That is, there is a high homogeneity between all these groups, and the propensity matching score really excludes a few patients. And, well, we observed that irrespective of the differences in the infection rate in the COVID patients, according to the timing, there was a significant difference. And the earlier the tracheostomy, the lower the infection rate and many other medical complications secondary to the COVID. So Other point that I want to mention is the post-tracheostomy care. I will mention just 3 studies. I think those are the most important. There are many other studies without, in my opinion, obviously, so clinical relevance. The first one was published in the US in a long-term care unit by Tapping Group. They reported 3 important conclusions. That is that many patients are transferred to a long-term unit without any attempt to disconnect from mechanical ventilation, and that reflects the situation that many critical care clinicians do not abort this problem with the energy necessary to finally succeed. So once the patient is transferred, many of them are directly weaned from mechanical ventilation without any effort. And well, what this study adds to the topic is that when you disconnect from the ventilator, according to a specific protocol, you accelerate the disconnection, the definitive disconnection from mechanical ventilation. And well, this include patients unweanable, in my opinion, and that's why this study finally have close to 30% of patients who cannot be disconnected from mechanical ventilation. And this is somehow different from the following study. Sorry, and another point here is that the third conclusion of this study is that patients who have a lower functional respiratory reserve have the benefit disconnecting from mechanical ventilation is lower than patients who should deserve a greater effort to disconnect. This is important because all the post-tracheostomy care aiming to accelerate disconnection from mechanical ventilation generates aerosol and air particles. And during COVID, this has been a concern for safety reasons of the healthcare workers. But, well, many reports have finally concluded that the risk for COVID transmission to healthcare workers attending tracheostomized patients is really, really low. And even more at this time of the critical illness of the infection, because most patients, when get this part of the disease, have a negative PCR. So the other study I want to mention is similar. It includes the disconnections from mechanical ventilation. And the other point of this study is that although it has never been tested specifically, high flow, not high flow, but conditioning the air should be always applied directly to the trachea in a patient when it's disconnected, because we are administering not ambient air, but medical oxygen and air. So we should conditionate all these gases applied directly to the trachea. In this case, increasing the effective airway diameter, that is deflating the cuff, changing to a fenestrated cannula with a fenestrated inner sleeve, accelerates weaning, and in this case, close to 100% all patients were finally weaned. Obviously, this study excludes some patients that were included in the previous study, and that's why we obtained such a good winning rate. Another point is that we observed a significant reduction in the infection episodes, and probably the combination of deflating the cuff, allowing, and the high flow directly connected through the trachea, to the cannula, sorry, allow an upward flow around the tracheal cannula, reducing microaspirations, and that's the main physiopathological mechanisms of pneumonia here. And the last one is published last year in the New England. This is a clinical continuum. You wean the patient from the mechanical ventilation, and afterward you continue until you decannulate him or her. So that's the second part of the previous study. In this case, application of high flow continuously while disconnected from mechanical ventilation and changing the clinical standard to decannulate this patient that previously was a cupping trial that is occluding the tracheal cannula for at least 24 hours and changing this with a measurement of needing of frequency of needing of suction in respiratory secretions accelerate close to 1 week the time from weaning to the cannulation, and even further reducing the infection rate of nosocomial infection, winning the cannulation failure, and many other outcomes that, well, obviously capping trials are really overload for patients with a reduced lung and respiratory reserve. So to conclude, because I'm out of time, yes, recent evidence supports early timing of tracheostomy, even more in COVID patients, improving winning tracheostomized patients generates aerosol particles, but this seems not to be a clinical problem for healthcare workers. Swallowing and airway obstruction should be checked early during weaning attempts and not after weaning during the cannulation attempts. The cannulation test can overload the respiratory system. That's why we should not cap the tracheal cannula, and conditioning inspired medical gases along all the clinical attendance of these patients is a benefit for them. Thank you so much.
Thank you very much. We need to move on to the last but not least presentation by Professor Paolo Pelozzi from Genoa about the improvement of tracheostomy care.
Thank you very much. It's a great pleasure to talk about tracheostomy, and I will try to show you some additional ideas and possible proposals to think more about this technique. First of all, the surgical and percutaneous tracheostomy. This is one dated now, but one of the most complete meta-analysis that we performed some years ago. And we clearly showed that when we compare surgical versus percutaneous, percutaneous technique is characterized by less total bleeding. Sometimes, if physicians are not trained enough, might be associated with more technical difficulties, and most importantly, with less general postoperative complications. And we also found that when we compare the blue rhinos, so the single dilator versus, for example, Greeks, in general, the single dilator was even better than Greeks. So overall, the first message is that percutaneous is the standard, the technique of choice in patients requiring tracheostomy. And if we look at the different techniques in different areas in the world, in Europe or outside Europe, you see that in Europe, the most common technique is the single dilator, followed by the Greeks, while outside Europe, both techniques are comparable. And so this means that surgical techniques are, again, extensively used in countries, especially outside Europe. There are different complications. This was an Italian study, but just showing you that the bleeding controlled by local pressure is the most frequent, the puncture of the endotracheal tube cuff or the tube, while others are less. And similarly, when we look at the late complication, again, the bleeding but controlled by local pressure is the most common. So complications in general are quite rare. The debate about early and late was discussed, and again, there are different studies on that. This was our survey. First of all, prolonged mechanical ventilation was the most frequent cause for tracheostomy, followed by prolonged weaning and patients with neuropathologies. The most frequent timing, as you can see here, is around 7 to 21 days, but the most frequent is between 7 to 15 days, so between the first and the second week. This is the meta-analysis that was showed before. There are many of them. Some of them did not find difference, others found other difference. Yes, in this most recent, they found a reduced VIP, but again, this was not stressed before. The I-square, which means the variability of this data is significant, is very high, so I think that the quality of this meta-analysis in general is quite poor. So we have not to take any final conclusion. It's true that it was associated with a reduction in duration of mechanical ventilation, no effect on mortality, but most important, remember that you need to do this clinical choice, you need to tracheostomize at least 1/3 of the patient who will really did not require tracheostomy. So personally, I'm not in favor of early tracheostomy in critically ill patient in general. There are some population that may require attention. This is our study where we recently published in more than 4,000 brain-injured patients, and we found that with time there is not much difference, a rate of tracheostomy around 70 to 20%. The time from intubation you see, again, is between the first and the second week, even in brain-injured patients. And percutaneous technique, again, is only 50–55%. So many people use surgical tracheostomy, and I hope that after this talk, when you go home, most of you will not use any more surgical tracheostomy, except for few cases. And there are some data, these are very recent, again, meta-analysis, but they include randomized, observational, retrospective, so very poor quality. A sort, again, of reduced VIP in a patient with a traumatic brain injury, but again, no effect on mortality. This is in stroke patients, again, very few studies, reduced VIP, but with some trend towards reduced length of hospital stay, but you see the data are very poor and most of them not from randomized sites. So we need studies. There is one study ongoing, randomized, is a limited population of patients, 200 and 200, 300 and 300. I think this is something that we have to investigate in the next future. COVID, this was one paper that we did at the beginning of the pandemic, where we found that very few patients were really early tracheostomized. And this is the Italian study. This is a prospective study. And we look at observation. Of course, the median time was 15 days, so half patients before, half patient after. In a quite large population of patients, but there were no difference in terms of outcome and in terms of mortality. In the analysis, early tracheostomy was associated with a little bit shorter ICU stay, but there were no difference in outcome. Also, percutaneous were associated with shorter as compared to surgical, so different effects combined. And again, infection, post-tracheostomy infection were more frequent in surgical compared to percutaneous. So our feeling is that even in COVID-19, we should be very careful before to use very early tracheostomy. So I think we should use the same rules that we have in other patients. Ultrasound guided, this is a randomized study, what we did comparing ultrasound with fiber optic. I am in favor of fiber optic, we always use fiber optic, but ultrasound can help to better identify the anatomical areas for the tracheostomy. And in case we have not the fibroscopy, that we should not we showed that as anyway similar effect as compared to fibroscopy. So we use a combined technique, but we prefer anyway to use the fiber optic. But ultrasound is more and more used. And again, we did a meta-analysis on the few studies, including ours, which is the largest, that we showed no major diff. So remember that ultrasound is a good technique to be applied together with fibroscopy at the tracheostomy. Respiratory assistance during tracheostomy, this is, again, some experience some years ago. You know the difficulties when we introduce a fibroscopy, especially in the tube, so we developed a double tube here so you can have one line just for the fibroscope and one for the ventilation. And we were able to show that this technique allowed to maintain oxygenation and to preserve the CO2. So this is some possible technical advantage that you can have in practical terms to optimize the tracheostomy technique in our patients. These are some general recommendations. So, of course, we need a sedation, analgesia, and neuromuscular blocking protocol, minimize the procedural time. So we believe that the best team should be available in high-risk patients. Most of these are not elective, so are not emergencies, so are elective. Use the smallest fibroscope when we are using this technique. We prefer to use a pressure-regulated volume guarantee at low tidal volume with a relatively low rescue rate. Probably we use too much FiO2 in our patients and should be modulated on the saturation. And I show you that there are some new devices that can help further. We know even something more about different humidifiers when we apply the oxygenation. And for example, in this study, we showed that at low minute ventilation or higher minute ventilation, when we increase the oxygen in the trachea, we reduce the efficiency of the conditioning. So what we suggest, this is in different models, always the same. Don't use a flow of oxygen higher than 2-3 liters when you oxygenate the tracheostomy. So take care of this issue, which is extremely important in order to avoid reduced efficiency in terms of conditioning. The other point is mortality in tracheostomized patients. Many studies, this is another important point. Why not to tracheostomize too much and too early? Because independently where we are coming from, ICU, winning units, post-acute care, mortality at 1 year is around 60 to 70%. So patients who require tracheostomy are high risk to die. So it's not only technical issue. It's a quality of life issue. And in fact, these are different data, but they show you our experience. Many patients have speech difficulties, coughing, shortness of breath, swallowing, and so on. So tracheostomy has to be performed only when necessary, not just say, okay, early tracheostomy is better. You have to think about the consequence for the patients and the relatives. Look at this data, mortality very high in patients with respiratory failure or neuro. And you see here the level of quality of life, which was very poor, especially in patients with neuro. This is another issue that we have to consider, that when patients require a tracheostomy, this is a clear monitoring of severity of the patients. So we have to think in advance, not only about the technique, but also about the consequence. So this is a shared approach that I think we should have in our units. So clear indication, clear guidelines for the technique, the timing we discussed, which physicians are involved in our, of course, unit. We are anesthesiologists and intensivists. A clear ventilation protocol with the use of ultrasound more frequently, a clear sedation protocol and airway management. The fibrillary bronchoscopy should be mandatory, in my opinion, and a register of the complication and the difficulty should be maintained in our units. So tracheostomy in intensive care, in the patient and family have never to walk alone. I show you that there is something after tracheostomy. And these are the main concepts, in my opinion, only when absolutely necessary. After careful multidisciplinary evaluation and discussion, it's not a single person decision. Taking into account life expectancy after STSU and hospital discharge, very important. And of course, there's to be individualized based on these conditions. So we have to reduce the number of tracheostomy, not to increase, in my opinion, and in order to avoid this consequence of tracheostomy that we don't see. This is my last slide. Percutaneous tracheostomy is the first choice, and I hope that surgical should be abandoned, except for some very rare clinical case for anatomical condition. The indication are prolonged mechanical ventilation expectancy, difficult weaning, and neuromuscular diseases. We have to remember that there are intra and postoperative possible complications to be monitored. We suggest a relatively late tracheostomy, not earlier 10 days in most of cases. Perhaps in brain injury patient might be performed earlier, but then we have the problem of intracranial pressure monitoring. So anyway, we are waiting some days, and new studies will try to answer to this question. General bundles are important to have in your unit in order to optimize the procedure. Consider the quality of life is very poor and mortality is very high in tracheostomized patients coming from critical intensive care. Ethical issues has to be considered when we take a decision. And again, this is my conclusion. When we are talking about tracheostomy, we have not to talk only about a technique, but we are talking about individual patients, families that, again, never walk alone. Thank you very much.
Thanks a lot for this clear-cut talk. Thanks a lot for everyone attending the session, this late session. Thanks a lot to all speakers for their fantastic talks.